So this is a group of diagnoses. Basically, well, for me as a clinician, when these kids are diagnosed clinically, they're really hard for me to tell apart just looking at them clinically. So this is one of those cases where we really do rely on your help.
And you cannot get those kids to cooperate with your examination.
Yeah, they're yay big.
Yeah.
They're not going to listen to my instructions. Yeah, so we have to really rely on your help.
Okay, well, let's see what I can do. I actually like these as long as they're straightforward, as I expect. The thing with the congenital myopathies is that they're described based on what you see microscopically. For instance, central core myopathy. There are core-like structures in the center of some of these myofibers, and they termed it that. And then this is an electron microscopic image, Z-bands, and Z-band-like material forms these rod-type accumulations.
So those are actually Z-bands that have been malformed to become those.
Yeah, due to the genetic defect. And you see them. You can see them by light microscopy as well, but this is more definitive diagnosis. And so they called it Nemalin or rod body myopathy. And then there is the centronuclear myopathy, where this is a really small child. That's why all the myofibers are so small and round. And you see that all of them have central nuclei. And the ones that you don't see, the section just didn't pass through the nucleus. So that's how they go. And it's a very relatively easy diagnosis and straightforward one. And these kids, for the most part, do well. They may be a little weak, but after a certain point, they're very stable.
All right, we just spent a lot of time talking about muscles. Let's jump to the next section, which is talking about the neuromuscular junction. So I don't remember if these guys talked about the neuromuscular junction, but let's take a refresher as to what happens there. So I think of 4 or 5 steps. One is the nerve action potential happens. So you have a nerve action potential coming down the axon. Then you have a calcium influx towards the end of that axon that because of voltage-gated calcium channels. So that happens. And then that leads to a release of acetylcholine into the neuromuscular junction. So you see that illustrated right here. This leads to an interaction with the acetylcholine receptors here, and then that leads to a depolarization of the muscle, and that lets you do stuff. So that's the whole idea. So what we're going to do is, now that we have the basic outline of what happens, let's talk about what goes wrong, because that's what we wind up looking for anyway, or that's what our job is, to diagnose. All right, so the first thing that could go wrong, we talked about the calcium channel, So if you have an antibody against that, that'll happen, as illustrated here. That prevents everything downstream from happening. So the disease for that is called Lambert-Eaton myasthenic syndrome. It's sort of a dumb name. We'll talk about something called myasthenia gravis in a bit, but this, when you see it, looks a lot like some of the muscle diseases that we've been talking about. So these patients, if I see them, they have a lot of proximal weakness, shoulders, hips, and they have a couple of interesting things to go with that, though. So one, they have autonomic symptoms, the most common thing being dry mouth. And then the other thing is they'll have reduced reflexes. And then the third thing that I see is something called facilitation. So what that means is I'll ask them to do something. The first time they're a little bit weak. I ask them to do it again immediately. They get a little bit stronger. Not like massively stronger, but enough that you can notice it. So I look for those things when I make this diagnosis. And then we confirm it by looking for voltage-gated calcium channel antibodies, okay? And that's sort of your buzzword, both for exams and for real life. You can't make this diagnosis without the antibody.
Hint.
Yeah. If you do make the diagnosis without the antibody, I'm going to question the diagnosis, to be honest. The next one we're going to talk about is botulinum toxins. So basically what happens here, we talked about releasing acetylcholine into the neuromuscular junction into this space. And so this happens through these little yellow circles, vesicles, basically. And what happens is there's a whole complex. Some people call it the snare complex. And because you have toxins that prevent that from releasing, these get stuck. It's a little bit like being stuck at the airport here. You would think that wouldn't be a problem, but because it's so small, but it is.
There's only one hallway. And
I know, yeah. So you get stuck and you're waiting, you're ready to go, your bags are packed, but you're stuck, right? So you can see, what you'll see here is, you'll see what we call a descending weakness. Usually symptoms start around the face area, maybe sometimes with breathing, and then they work their way down to the rest of the body. And there's like 2 or 3 clinical scenarios to think about. One that you'll see in books, but doesn't really happen, is if a baby has unpasteurized honey. I've never seen that before. But the way that I've seen it more frequently is that mom and dad live by a construction site. And then because of that, spores get kicked up by the construction team, the baby ingests it, and then you start seeing some of these symptoms over the course of a few days. The other thing is you see someone trying to, I don't know, preserve food on their own. They do a terrible job of it, and even though the can was supposed to be this big, but it's this big, they eat the thing anyway, and they get these symptoms. So don't make that mistake.
So the bottom line, don't buy the expanded cans out of the grocery stores.
Yeah, and don't can your own food unless you're actually good at it. All right, and the last one, we're going to spend a little bit more time on this, is myasthenia. So this, you're going to see, I think out of all these, you're going to see this one the most in the clinics. But myasthenia happens because you have antibodies against the postsynaptic acetylcholine receptor channels in the muscle. So basically, those muscles are ready to go, but there's something blocking the reception of the acetylcholine, so they can't do anything. I want to make one time out, though. We'll step back a little bit. The botulinum toxin, just as a reminder, we use that for therapeutic purposes now, don't we?
Yeah. I've been hearing that a lot.
Yeah, so
I'm still young.
I know, that's how we use it.
Yeah.
Right? So you'll see botulism, but botulinum toxin, you'll see it. I think traditionally it's been used for cosmetic purposes. I've seen it more used frequently in headaches, actually, too, to help relax muscles that could be causing muscle tension in the neck.
Migraine treatment, I've been reading about those things.
Yeah.
Interesting.
So you'll hear more about that going forward. All right, let's jump back to myasthenia. We talked about the antibodies. Let's spend a little bit more time talking about some of the features associated with that. Let's talk about some of the features you see in myasthenia. So for me, the biggest thing is fluctuating symptoms. So you get symptoms that sort of, the typical story for me is someone wakes up, they feel good. Later on in the day, like in the afternoon, they start to have symptoms. They worsen with fatigue, so they had a long day of work, or they went to exercise, they start to have symptoms. If they take a rest, or they just get full sleep, the symptoms almost completely resolve, or they at least get a little bit better. And the symptoms I look for are relatively specific. A lot of facial symptoms, so ocular symptoms, so ptosis, which is a drooping of the eyelid, diplopia, which is because you get double vision because the eyeballs don't align, so you start seeing two of the same image. If it's really bad, you'll start to see more bulbar symptoms, we call them. Bulbar being a really fancy word for brainstem involvement, so difficulty with speech and swallowing, dysarthria and dysphagia, respectively called. And then you'll have issues with respiration, so shortness of breath. And then some people will have more generalized limb weakness to go on top of that as well. They just, overall, they feel a little bit meh.
Yeah.
I tend to rely on the first 3 sets of symptoms to make my diagnosis, and then couple that especially with a fluctuating nature of the symptoms.
Okay.
So if someone has these things, but they never really change during the course of the day, I'm doubting it's myasthenia.
Okay.
So that's an important part for me to make that diagnosis. Once you get past that, how do I cinch the diagnosis? There's a couple of ways. One is through antibodies. We mentioned the acetylcholine receptor autoantibodies. That's the most common kind that we use. For people who have negative antibodies there, we'll check another one called muscle-specific kinase, or MuSK. So that can be positive about, I want to say, 80% of the time if you have someone who has negative acetylcholine receptor antibodies. There's a couple of other commercially available antibodies that have come out on the market recently, but I won't mention them today because they're out of the scope of our discussion here. Another thing that you might hear about, we won't go that far in depth with this, is a type of study called a nerve conduction study where we do repetitive stimulation. And basically the buzzwords to look for this, we do repetitive stimulation where we're stimulating a nerve to activate a muscle. We actually look at the muscle action potential that's produced from that muscle, and each time you stimulate or zap the nerve, that muscle action potential will go down. So we look for a decrement being the key word. So treatment. So what do we do for these folks? Well, there's a couple of ways to think about it. If someone is really, really sick, like they're in the hospital, they have we call it a myasthenic crisis, so they have difficulty with breathing or some other really bad symptoms, swallowing, whatever it might be. There's really 2 main modalities we do. One is we do plasma exchange, where we actually introduce a big line, take out their blood, we filter out, we take the antibodies that are causing the problem and then give them back their blood. And the other thing we might do is called IV immunoglobulin, so IVIG we often call it in the hospital. And we think what that does is it prevents some of that interaction and that leads to the blockade of the acetylcholine receptor antibodies from happening. So almost like having like an offensive lineman block those defenders so that you can do your thing.
Mm-hmm.
The most common thing for me, since I mostly work outside the hospital, there's a couple of things. One is if someone comes in for the first time and they have fairly mild, we almost call them annoying symptoms with my patients, I use acetylcholinesterase inhibitors. So if you think about that, your acetylcholinesterase is there in that neuromuscular junction so that you don't have that acetylcholine just sitting around. If we prevent those from doing their thing, you'll have more of the acetylcholine available for the muscle to use, and so whenever the patient wants to do something, the reaction is a little bit stronger. So that medication is called pyridostigmine. So it's pretty good, except that for some patients it isn't enough. So the other things we might use are more immunosuppressive therapies, so oftentimes prednisone, other steroid-sparing agents that we mentioned before, azathioprine, mycophenolate, and then more recently people have been doing a thymoma for these patients as well. There's been data in the last 3 or 4 years that doing thymomas for patients specifically with acetylcholine receptor antibodies is a good option if they're having issues despite trying some of these other chronic therapies. It's not usually your first to go to though. All right?
Come to think about it, I always get sleepy in the afternoons. Should I get checked?
That might just be your work.
Oh, okay. Probably. You will find out if you haven't already that whatever you are taught, you think that you have that disease. That happens a lot with psychiatry in my brief experience.